everybody, it's Ben back with Master Medics for this week's case study on management of hypoglycemia. Just as a reminder, you may start your free 3-day trial at mastermedics.com. So back to this week's case study, you are dispatched to a middle-aged female who's having an altered mental status. You found her in an apartment that's very disorganized, very cluttered, very messy, and she's surrounded by alcohol bottles as pictured here. Place is very unkept, trash, debris. So you see that the patient has a GCS of 223. She's responsive to painful stimuli, has incomprehensible sounds. Her pupils are PEARRL, her airway's patent, her breathing is regular, respirations of about 18, finger stick of 36. So certainly are concerned there for that hypoglycemia. All other vitals are within normal parameters. Blood pressure 106/70, 96% on room air. Everything else checks out okay. Appears to just be hypoglycemia. So the questions that arose after getting that notification from the neighbor that the patient drinks like a fish, and law enforcement are on scene and are confirming this same story that they have encounters with her and known of chronic alcohol abuse. So what are going to be our differential diagnosis in this? Once we've got that differential diagnosis, what's going to be that treatment plans and any special considerations for this patient? So right now we're thinking, well, it's simple hypoglycemia. The patient is, just a middle-aged female, although she's quite petite, just hypoglycemia, even though we don't know any of the medical history other than definitely identifiable alcohol abuse. She seems very malnourished, very petite, and just going with that basic history of alcoholism, and she's hypoglycemic, which would cause all of these symptoms of the altered mental status, the pale, cool skin, so on. Okay, so in the initial treatment plan, we're going to be thinking about giving dextrose to raise the blood sugar because simply they are hypoglycemic, so we're going to supplement some simple glucose into the body to try to raise that blood sugar. However, this patient has a complication. Due to her very petite build and malnourishment, you're having a very difficult time getting IV access. So after several IV attempt fails, resort to the optional process in your protocol for intramuscular glucagon. So your local protocol calls for 1 milligram of glucagon to be given intramuscularly. So we know that the onset of glucagon can start to begin to react within a few minutes. Peak effect is at about 10 minutes, and it has a duration of approximately 45 to 60 minutes for total processing, but that peak effect in that 5 to 10 minute range. However, after reassessing this patient after 5 minutes post-glucagon administration, all the vitals are the same. So still got that poor GCS, and ultimately the big look, that blood glucose is still remaining low. She is still altered, no improvement. So what's going on? Why would this be? So why would we give something that's supposed to raise the blood glucose? Why is it not working? So why is this patient's blood glucose not increasing? So after no change in 10 minutes, you and your partner decide that this is now a load and go. There's no improvement in the patient. You're concerned. You're just not sure why nothing is working. So what would that be? All right, so let's break down the breakdown of how glucose is built up into the body. So our primary source of glucose is through intake of food, through carbohydrates. Simple carbs, complex carbs, everything is how we traditionally metabolize to develop glucose in our body. So once we break down all these carbs, everything then gets transitioned over in the stomach, it's metabolized, broken down, and that glucose is now sent through the small intestine and then sent into the bloodstream for our glucose. So that's why we check blood glucose in the blood, because that is where the glucose is circulating, going around to all the cells for ATP production and glucose utilization for energy for our body. So let's break down some more of this stuff. So we have some basic terms we need to understand. We have glycolysis, which is the breakdown of glucose. So if we kind of break down this medical terminology, glyco relating to glucose or predominantly this, glycogen, and olysis or lysis at the end means, as that suffix, that is a breakdown of something. Okay, so in this, we are breaking down that glucose product. So we use that to break down for ATP production. So we know that ATP is produced through the Krebs cycle. Okay, so the most basic concept of that is we need oxygen and we need glucose to make ATP. Super straightforward things. Hopefully everybody has a good understanding of that. Now, some other things we need to know is byproducts of that. With that adenosine triphosphate, that ATP production, we produce H2O, some water. So we secrete that out through our renal system. We pee out that waste product, and CO2, we exhale it. So our renal system and pulmonary system are our buffering system. So we exhale it out, we pee it out. That's how we excrete that extra waste. Also, a thing to understand is with this, we are warm-blooded persons. Okay, so with that, if we really broke all this down into a really long, drawn-out chemical equation, kind of thinking way back to chemistry class, this would be considered an exothermic reaction. So with that chemical breakdown of ATP production, there's also heat. Okay, so in that, that's what makes us our regular temperature of around 98 Fahrenheit. Okay, so without that, we're having less heat production. So with less heat production, our skin is going to be cool, clammy. Okay, so that's why we start seeing patients with inadequate perfusion, inadequate oxygenation, inadequate glucose. They have low body temperatures. Why it's so important in our primary assessment to be touching this patient's getting a good body temperature. Okay, so glycolysis, breakdown of that glucose into that ATP. The next process is glycogenesis. So breaking this down again, ESIS, that suffix means to store. So we are creating storage of glycogen. Glycogenesis. Okay, so we are storing glycogen. So what that's meaning is the excess glucose that's being produced or being metabolized, sent into the blood vessels. Once everything's kind of measured out, the excess amount of that gets stored in the liver and in our skeletal muscle in little reserves glycogen. So glycogen is produced from leftover or excess stuff from glycolysis. So again, we store that excess glucose in the liver as glycogen, and also some goes into the muscles. Next term, terrible pronouncing these, glycogenolysis. Okay, so basically that is the breakdown of glycogen. So glycogen is broke down from the liver to produce glucose. So we know that the pancreas is responsible for releasing insulin so that glucose can get into the cell, be metabolized, transported, and all that. The pancreas still also releases glucagon, just like the glucagon which you gave this patient, releases glucagon. So it goes and it is aiming for these hepatic receptors in the liver. So when that pancreas releases glucagon, it's hitting this hepatic, relating to the liver, this hepatic receptor in the liver to convert through, back here, glycolysis, to produce glucose. So another phrase A less common way of producing glucose is through gluconeogenesis. So, breaking down this term again, genesis process. It's a process of making new neo, similar to the word you've heard of neonate. Neo being new glucose. So this is a process of making new glucose through a different way. So the brain starts to be thinking, man, we need extra glucose. We're not intaking in a traditional route. We're not metabolizing anything. Uh, At this point, we've depleted the glycogen reserves out of the liver through the hepatic receptor from glucagon released from the pancreas. So the brain is trying to look for other places. We know that muscles, that they are very dependent on getting glucose for energy production for all their action potentials and whatnot. So the brain starts thinking, hey, I know I got a backup system in the skeletal muscle. So let's go there and we're going to harvest some of that. So we're going to pull all of that out to produce new glucose. So at that point, it's the brain's like, man, we really need some glucose, but where can we get it from? There's no extra glycogen stored in the liver to produce our glucose, so we've got to figure something else out. So it starts going back to the backup methods. So like the backup generator in a house, this is the backup space where we don't want to rely on it, but it is a process the body can utilize. Okay, so now let's break this down of maybe why this process didn't work for this patient. So you had the patient who traditionally we would start an IV, give glucose, simple dextrose to raise the blood sugar. It's fast metabolite, get in, burn, get ATP production going and going and going again. But the reason, and backed up by research for a couple different ways of why this does not work. So in this patient, remember, she is middle-aged, chronic alcoholic, very petite, very frail, appears to be very malnourished. So if her only intake really is alcohol, she's not getting any kind of carbohydrates in to develop metabolize glucose, let alone to develop and store any kind of glycogen in the liver or the skeletal muscle. Hence why they're frail, no good muscle production because there's nothing in there feeding the cells of the muscle, so there's no muscle growth. In fact, it's mostly atrophy because the body for a long time has been going through that process of gluconeogenesis and has some muscular wasting because that's what it's using as those reserves. Other way, intoxication. If the liver's primary job is to filter out toxins. So in this mode, when the body has extreme alcoholism or extreme toxins, it's going to focus on that primarily, other than trying to release extra glucose. It gets distracted saying, oh, things are really bad. Let's filter out all these toxins and just trying to worry about all that intoxication, all the alcohol that's in the bloodstream, more so than going through other processes of glycogen breakdown through glycolysis and producing that extra glucose. So its primary focus is worrying about that intoxication, trying to detox the body. Additionally, there can be other causes such as pancreatic or hepatic complications, such as there's instances of it happening in liver transplant patients, patients who have tumors or other various diseases who are complicating their pancreas or hepatic impairment. So let's go for some icing on the cake here. See what I did there? So we've been taught that thiamine is something that is detrimental that we need to be giving prior to glucose administration, whether that is through simple glucose or any glucose that's going to be produced in the body to get thiamine. And so where this came about was from a study in 1981 from Watson et al. So what they found that there were 4 cases of patients who were hypoglycemic who were given pushes of glucose and then had a neurological crisis, which would be described as Wernicke's-Korsakoff's. Also in that study, those patients had all those symptoms reversed with given thiamine post glucose administration. So those patients were chronically malnourished alcoholics, same as the patient in this case study. So their symptoms of the neurologic crisis caused by Wernicke's was simplified and resolved post glucose administration. However, um, the thought is we need to be given thiamine prior to that glucose administration to prevent exacerbation or an acute onset of a neurological crisis such as Wernicke's. So with that, our dose for thiamine is going to be that 100 milligrams IV or IM. So if we're given a dextrose, we've already got that IV started because we have to have that IV to give dextrose, D50, D10, D25, whatever concoction we have, to prevent necrosis. So we can give that thiamine IV if we're going dextrose. If we're going glucagon, giving that thiamine IM as well. So it's going to be 100 milligrams IV IM, and to that patient who is malnourished or believed to be malnourished or have alcoholism or known thiamine deficiency or believe Wernicke's or any type of history. Okay, so how that all is working. So if there is no appropriate diet, there's no thiamine. We're obtaining thiamine, that B1 vitamin, through natural digestion, just different foods. Thiamine, B1 is pretty robust in a lot of just natural foods that we eat. So B1 is absorbed through a diet. But if this patient's only diet is alcohol, there is no B1 in alcohol. So with that, the body has now shifted into a process of anaerobic metabolism since we're not efficiently operating in Krebs cycle. With those anaerobic metabolisms, we know that a big thing is lactic acid from anaerobic. Anaerobic lactic acid. That's the big thing. We know that the body just doesn't like acid, puts a strain on it, complicates a lot of cellular processes, just no good for the body. So during glycolysis and in processes of gluconeogenesis and everything, we're in anaerobic metabolism, increasing levels of lactic acid. In these episodes, if there is no thiamine, the thiamine helps multiple enzymes and everything to help metabolize that into adequate ATP production. So with that excess glucose, without thiamine to help those enzymes converting and everything and to push that glucose forward in the chemical process, there's still going to be more acid produced. Okay, so in these alcoholics, one thing, the big issue with Wernicke's is that alcoholism can cause lesions on the brain. So those parts of the brain aren't functioning well on a normal day. So in these states of hypoglycemia with a sudden change in glucose without that thiamine, it's also going to make those parts of the brain not function well. So increased acid levels causing just some major cellular malfunctions on that brain. So with that thiamine administration, it's helping those enzymes push that glucose forward through the chemical process, create adequate ATP production, pushing towards that aerobic metabolism and helping those parts of the brains function to the best of their abilities. Maybe not necessarily perfect, but preventing those neurological crises such as Wernicke's Korsakoff's, which was discovered in 1881, almost to the day 100 years prior to the study showing where neurological crisis happened without thiamine administration. However, there is limited research that it is truly making a big thing. A lot of the research supports that patients are receiving continual high levels of, not necessarily high levels, but just continual dextrose administration. The thiamine is key of measuring the amount of thiamine. So, based on all this research here, that thiamine is best to be given in these initial doses of IV or IM, and then supplemental after that PO. So, what we're doing in EMS already. It also states in there, though, that however, that there is not necessarily anything to indicate that it is detrimental to give thiamine prior. In all cases that have been studied of Wernicke's encephalopathy and things happening, which is ultimately rare, it's something, and some studies around less than 10% of cases of dextrose being given in hypoglycemia that Wernicke's or neurological issues are happening. So, but however, the research says that not detrimental, have to give thiamine first, but also there are no ill effects from giving thiamine to somebody who does not have Wernicke's, who does not have malnourishment, who's not thiamine deficient. That it's just a naturally occurring vitamin that we are intaking anyways, and our body metabolizes it, breaks it down, and it's a waste product after that. So overall, research non-conclusive. There are some agencies throughout the U.S., Canada, and the world who have went away from thiamine just because of the lack of use of it, and then research is not completely supportive, saying that it is detrimental to use before. But even if they do have it, that their symptoms in Wernicke's have been resolved with thiamine post-glucose administration. However, the standard still is being taught that thiamine to be given to those patients who you're believed to have Wernicke's, especially, or some type of malnourishment or something that will inhibit or make their metabolism not very efficient. Well, thank you all for joining into the case study. I hope this kind of opened up some eyes on some having to know those backup methods of, if glucagon's not working, why that glucagon may not be working. Also, kind of a breakdown of glycolysis, gluconeogenesis, and the process of how our body's breaking down glucose and how we're producing glucose in the body, and just the backup methods that are there. So, thank you all for joining in. I'll see you next time.